Hello everyone. I assume you can hear me and you can see me. Uh, First of all, I would like to thank the Scleroderma and Raynaud UK for organizing this question and answer session because I suppose it will be extremely useful for the patients and also for us to communicate our knowledge and facilitate your treatments. So, but I'm just going to give you a little bit of an introduction of what I do. So basically, my background is podiatrist. I am in a very privileged position where I have an NIHR clinical lectureship, which means that I have 50% of my time dedicated to clinical work and 50% of my time is dedicated to research. So whatever I learn clinically kind of fits into the research, and whatever I do in research fits into the clinic. So it's very well amalgamated in that aspect, and then we can give the best treatment we have currently. So what we're going to be doing today is if you could start sending me questions through the chat. I'll be reading them, and then I will be answering anything that I can to help. Then I also have some questions here that I can read if any of you, have written the questions previously and need some answering. So there you go. I can see Sheila. Good morning, Edith. Good morning to you too. So we are getting there. So if while you're writing any of the questions that you might have, what I'm going to do is I'm going to start maybe answering some of the questions that were originally given it to me. Please note one thing. This is advice to the best of our knowledge for the information that we're getting from you, but this doesn't mean that overrides anything that could be seen clinically, because when you have a presentation on problems in general, like any rash or anything, at the end of the day, that has to be assessed by the clinician and physically, because it is easier to determine the diagnosis than it would be just by having a conversation. But at least what I can do here is signpost you where you should go and what are the basic things that we can cover that maybe you can do at home anyway. Right, so just let me read some of these questions here. Sorry, I've lost my mouse here. Should be somewhere. Okay, so making sure. Good morning, Liz. Paula asks good morning. So I have one question here which says, my skin is progressively tightening, particularly my feet and ankles and front of the legs, which that's the area that you would expect to be affected with the scleroderma. So, and it says there's so much that mobility is restricted and my feet are cold. I have so many sleepless nights and wonder what I could do to reduce the tightening sensation in my feet. Right, so extremely important, and there was already a question and answer from a dermatologist that you can also check. Extremely important with the scleroderma is to hydrate your skin. And the reason for this is because we know the fibrosis will tighten quite a lot of the skin, but also the same fibrosis, what it does kind of thing on the process is that it kind of strangles a little bit of all the sebaceous glands and things like that around it. So you are getting less hydration to that skin anyway. So for this reason, we always recommend to hydrate the skin as much as you can. You would probably see that your feet might become a little bit scaly. That could be related just to the not being enough hydration there. So to all my patients, I always say, if you can hydrate it once a day or even twice a day, depending how dry they are, and if you can make it into a routine really easily as if you're sitting down a certain time of the day to have a cup of tea, then make sure your cream is next to you on the settee, and then you can put it while you're doing that. So it's always trying to fit the kind of the treatment or the creaming time or the exercise time, trying to fit within a routine, daily routine that you have, like stretching exercise, and you can do it while you boil in a kettle, things like that. It's just making sure that you have some sort of routine attached to it, and then you won't forget to put your cream. Extremely useful for the tightening of the skin is to do stretching exercises. I know the ankle area and the dorsum of the foot, that is the top of the foot, it's kind of difficult to do more stretching exercises that you would do with your hands. But if you could just cream it first, hydrate it first, so the skin has the maximum flexibility, and then try to just keep pushing it down and massage it. And that would certainly stretch as much as we can from that area of the skin. Unfortunately, we don't have a solution where it would reverse, but in some cases, the skin, after a few years, they tend to kind of reverse into less tightening of it. So it kind of becomes a little bit more normalized, and not to everybody, but in some of the patients do. So just remember, cream it regularly and try to stretch it as much as you can, that area of the skin, and massage it. That will certainly help. Right, I have a question here from Paula. I get pain in my MTP heads, ball of my feet, okay? In my feet when I am walking, apart from wearing soft soles, any other tips? Right, yes, there is lots of tips for that. So, very important is footwear. Footwear is extremely important. Any shoes that actually have a sole that is padded will always help you more. So the example that I said is normally give is trainers that a runner will run a marathon with. They have to be very comfortable for them to run a marathon with. So anything like that have a lot of shock absorption, and it will help you. Also, it has a slightly rocker sole on the front, which by rocker means it goes a bit like that. So when you're walking, it kind of rolls you a little bit on the ball of your feet. And the reason for that is because while you're doing that, you spend less time onto that area of the ball of the feet, so then it hurts less. It kind of has less impact to the pain in that aspect. But very important is to wear the right insoles. So what happens on the ball of the feet is you have a reduction on plantar fat pad, which is kind of like the fat cells, which are slightly different to the normal fat cells that we find underneath of the skin. But what they do is they have a reduction, and they lost a little bit of their properties, because they become like a bit more what we kind of suspect, maybe either fibrous or reduced or reabsorbed. We don't know exactly what happened, but we know for sure through my PhD I found out that there was a significant difference between norms or controls and those with the scleroderma. So what you want to wear is to get some good insoles. And what I mean by good insoles is maybe not just the cushioning insole, but maybe get assessed by the podiatrist. If you have asked, some of you might know podiatrists as chiropodists, but now the common name for us is actually podiatrist. And just find a registered podiatrist, or within your rheumatology service, there might be a podiatrist specializing on these areas. And what they could do for that is they can do additions to insoles that will fit exactly what the shape of your foot is, and also they will check how you walk and where you put more pressure. And then they can distribute it by giving you an insole and putting certain additions or taking some of it. So it's very important that you get assessed properly. And also there is something that I found really useful, is what we call a metatarsal bar. And you can put it in the insole. It can be added inside it, or it can be on top of it. You can put it, and then that distributes the pressure from the ball of your feet, and it reduces the pain. We tend to find that is useful. Simple insoles, just padded simple insoles. We ran a trial and we found that there was no difference from what we gave the sham, which was the insole that didn't work, that we expected, that did not have any function. But what we found is both of the groups actually improved, those with the padded insole and those with the insole that were meant not to have any properties. But later on, when we looked back, we saw, because we had to make it look like they look similar, we added a cover to the one that should not work, and actually that probably gave a little bit more comfort. That could be one of the reasons. Another reason could have been that patients, by getting the attention, which it happens in trials, they were just getting a little bit more or willing to report that there was a change. So soft padded insoles are good, better than nothing, particularly those that have a cover like that has some sort of heating properties like plastazode. Those are good. But obviously, I always recommend, if the pain is there and you walk and it's on the ball of the feet particularly, and it's still causing you problems, get podiatry to check your feet, and they can give you the right insoles to distribute the pressure correctly from the area. So that covers the insoles. Let's go on to next questions. So just making sure I'm not Janet. So Lorraine, can I ask if they can be done about my toes twisting? I have lost a fat pad on the soles of both feet, but my toes are contracting on the pinky and the toe next to on both feet are twisted to the edge of the foot. So I'm walking on the side. Let me see more from that. This is getting so to walk on. I use Skechers Go Walk Memory Foam footwear. I also have another problem with the toenails lifting from the nail bed and are becoming detached. Can this be treated? Right, there's a few things. So you know now what is about the problem with the plantar pad. So we know there's a reduction, so then you will get more pressure because the bones are more closer to the surface area on the skin, and when you walk you will find more discomfort. Also, you're talking about twisting your toes, and I assume that there are different things. So it could be that you just have the common thing that patients might have, like the claw toes or the hammer toes, and that's a common thing across even the population that doesn't have any other health conditions. Or you could have what is called flexion contractures. And flexion contractures of the toes are hard to distinguish from the other pathologies that I explained previously. So what happens is that the tendons tend to be fibrosed and then they start to contract more. And then there is also a little bit of reabsorption on the bones, so the toes tend to kind of shorten. Now, again, similar than before, I would suggest get it assessed by a podiatrist because they would be able to distribute the pressure and also give you like maybe some toe props depending where it is, which will also help for your toes maybe not to curl in as much. And they are made with silicone and they can be molded to your foot and be custom made there and then when you go to the clinic. So I would say that's one of the things, again, check it with the podiatrist, but there are things that can help you, at least not to get so much pain or rubbing on the toes and things like that. Regarding the toenails, yes, we can see this in the scleroderma. It does happen. There seems to be like there is an extra growth on kind of like the skin underneath the nails, and then they sometimes tend to lift and they become like a little bit patchy. However, sometimes nails can also lift if they have a fungal infection. So when they become like patchy and white, sometimes they lift and there is a fungal infection. So just go and have it checked. Make sure that there is no fungal infection. And then if it's part of the scleroderma, unfortunately, we do not have a solution for that. So, where can we purchase the insole? Right. Regarding purchasing insoles, so the one that we used for the trial, it was called Orthotic, so Orthotic Duoform, and it was from Algiers. There's a lot of different type of orthotics available in the market. What I would suggest is one is an insole that will give you padding, and that is about trial and error, see which one works best for you. And the other thing is an orthotic that is, you can get it off the shelf in some cases, but sometimes what we do clinically, what we tend to do is made it custom made for the patient. So we take a cast from your feet, we'll make sure that we have, that becomes as a template, we send it to the manufacturers and they make one that it distributes properly. Custom made orthotics off the shelf, we can use as well and modify them, but I always would say have it checked by a podiatrist. The reason for this is the same reason that an orthotic can do you good, it could also do you bad. So if you are loading onto a specific place, let's say you are more loading internally, like more flat-footed, once we put an insole that gets you more into the right level, if we overdo it, you're going to go laterally and you're going to be loading the lateral side of your foot, and then it could create other problems there. So that's why we always say have it checked by a podiatrist, make sure that the one that you get in is the right one. And also it might take a few trials, like you try it, then we modify it, we modify it again, and eventually we get it right for you. So always make sure that that's the case. But online you can find those ones that are just padded insoles, which help you a little bit more. Okay, hi, just joined, so let me see. I twisted. Is there any research to find out how to stop the loss of tissue damage in our feet? Right, Kim. Kim is asking, is there any research to find out how to stop the loss of tissue damage in our feet? Right. First of all, I did my PhD. I did measure 121 patients' feet and compare it to 50 controls, which were normal with what we call norms. It means that they did not have any systemic diseases or any obvious diseases that affected their feet. So what we found is that there was a reduction in plantar fat pad. We don't know why it's happening and how to stop it, because what we believe this is part of the disease process. So there's a good paper with Chris Denton that actually explained about how the subcutaneous fat pad from under the arms, where they become fibrous on the fibrous areas, particularly those ones kind of started reducing because of the fibrosis process and actually became lost of the properties that the fat has, which one of them is insulation. The other one would be shock absorbency from any trauma that's happening. That's what the fat does. So in this case, it's part of the disease process, and how to stop it, that's, yeah, if we can find that, that would be very useful. So suppose within the next few years, if we have funding for those things, we might be starting to look into this a little bit more. But unfortunately, right now, we do not have the answers. Where can you purchase the insoles? We covered that one. Rhonda Rosen, I suffer from Raynaud, osteoarthritis, DVT, and pulmonary embolism. And I have noticed I am walking on the side of my feet. I have seen a foot specialist and they gave me insoles. They only fit in one pair of shoes. I have hard skin on the tips of my toes and my toes and heel. So I have hard skin on the tips of my toes and heel. Okay, so Rhonda, you suffer from Raynaud, osteoarthritis, DVT, pulmonary embolism, and you're walking on the side of your feet. And obviously, because you have the Raynaud as well, you will have other issues with the discomfort on your feet. So yes, when we give insoles always have a compromise. The compromise is the footwear. The insole is as good as your footwear, because the footwear becomes your platform. So if you have a very soft platform, like what we were talking, sketches are great if you don't have anything else and they are padded, because you might feel comfortable, but they have no support. So if your tendency for your foot is to roll in or roll out, if you have a very soft shoe like a Skechers, thing like that, whatever tendency you have, you will increase it because there is no support on those areas. So we always say that it has to be a good shoe, and by a good shoe, you can find it. It doesn't have to be just trainers. Trainers are good because they give you the cushioning, and they all normally have the right support. So when you look for a shoe, you want it to bend, or the tip of the shoe should bend, but the middle should not bend in the middle. So it should be rigid. So when you try to bend the shoe, it should not bend, because it bends too much on too many areas. Then whatever tendency you have to go to, you will increase that. So when we give insoles, we always say it has to bend on the front, but not so much in the middle. And it has to have those properties of cushioning soles. It could be rubber soles as well. It doesn't need to be just the foamy type of a style that has a trainer. It could be rubber shoes. There is Loving Clarks that would work because they are slightly wide fitted, and you can find, if you go online, I know it takes a while, but you can find the right one to fit the insoles. So it's just a matter of keep trying to find it. And I always recommend, every time you go shoe shopping, get the insoles with you. Make sure you remove the insole from the shoe, the original insole that comes with the shoe. Remove it if you can, and then put your insole in. Because the reason for this is, once we put the insoles in, we're taking quite a lot of space, and we might be giving you more comfort on the bottom of it, but your toes might end up rubbing on the top of the shoe because there is not as much space. So that's why it's very important for you to take the insoles with you and always try them with the shoes that you are buying. Make sure that you do that, and you will find them. There's also shoes online that actually they have wide fitting, and they have a deeper toe box, which is the box on the like where the toes are. So all those things you can find. Even there are insoles. Hotters, I think it's Hotters, the company used to make some sandals that you could remove the insole, put some Velcro dots on the insole that you have and the shoe and the sandal, and attach it. If you go with sandals and insoles, remember you always have to have some sort of fastening around the ankle and the front bit, because your foot has to be secured. Anything that slip-ons or anything that doesn't have any fastening or Velcro or lace-ups or zips or anything like that, that if it doesn't have it, it means your foot will slide back and forth inside the shoe, and it will just end up, one, creating more friction, and two, it won't sit onto the right position, and then the insole might not work fully as it should. So it's just a matter of keep trying, looking for shoes. And if the podiatrist that you saw, he might be, or she might be quite helpful, and if you talk to her and say, look, I bought these shoes and I'm not quite sure about it, before I try them, can I just show you and then give me advice to make sure that it fits properly? They should be able to give you that advice. So hope it answers this. So Sarah, is there anything to help nerve pain in my feet? It feels like electric shocks in my feet and traveling up the bottom half of my leg. Also feels like someone is sticking pins in my feet. Thank you. Right, Sarah, yes, there is. Now, nerve pain. We need to bear in mind there is different type of pains that we need to be aware when we actually have pain in our feet. And one of them is the mechanical pain that we just discussed, that is more to do with either not having enough plantar fat pad, or the joints being painful, or more when it normally is when we're walking, when we are doing exercise, when we are moving. That's what it's called mechanical pain. So that is one type of pain, but when you're resting, the pain shouldn't be there. Okay. The other pain is nerve pain. When you're getting all these pins and needles, or burning sensations, or even itchiness, that's part of the nerve. Or numbness that can sometimes combine with some of those pins and needles and burning sensation, and all of that's nerve related, and that's different because that comes systemically and is part of the disease process, but also something that we need to check and you need to discuss straight away with your GP or your consultant. And the other thing is the vascular pain that we get in. So that's what we call ischemic pain, and that pain tends to be more related, with the Raynaud you will experience it, because when you have no blood flow because of the Raynaud's attack, then you'll get it, and that's more constant pain. It's all the time. It's more persistent. It doesn't want to go, and sometimes it's the one that will, if it goes worse, and there is the pain is related to the capillaries and the blood flow of your fingers or toes, or any of the areas are compromised. Then what happens is the pain becomes more constant and can lead to ulcerations and can lead to other things that are more severe. So for that pain that is constant, is all the time, and it feels at nighttime, particularly if you're lying down and you're getting cramps constantly, and when you stand up it feels better because the blood flow goes down. Those type of pains, you need to go and check straight away with your GP and or your consultant. Don't leave them, because it's better to know, because it's systemic and it could be other problems, vascular related. So regarding the nerve pain, we tend to give pregabalin. So you can give a different type. Some people get amitriptyline for it. So it depends. There are different drugs that works differently. Some of them are for depression but work for the nerves. Some of the drugs are for convulsions, for epilepsy, but actually works for the nerves. So in different dosages, it works for different things. So the one that we found that it works quite well with us is pregabalin. An alternative is gabapentin. And these drugs works onto the nervous system, and what it does, it will reduce the feeling of pins and needles and burning sensation. You should persist to get the right dosage, because you have to escalate it slowly. And this has to be given by the GP or the consultant. And they would start maybe with different drugs and then end up with pregabalin. but and you cannot stop it abruptly. You have to kind of escalate, titrate down slowly to make sure that you don't get a withdrawal symptom. So if you go into those, then you have to follow the rules properly. But those should ameliorate